Yeah, good evening, everybody. Yeah, I hope my slide is visible.
Yeah.
Yeah, yeah. So, this is a topic that we recently published. So, we thought we'll have a small discussion on this because I think ultra congruent inserts have become kind of more popular over the last maybe 10 years or so. So, just to go back into history of where the, where we are discussing rollback. I think it all started with these guys, Dr. Insal, Ranawat, and Dr. Walker. They kind of produced the first globally used total condylar knee in 1974. So where both cruciates were sacrificed, and they used something like a little bit like a CR knee, where but with sacrifice of the PCL. And it did well, but there were two problems. Flexion was limited to an average of 90 degrees, and high rates of tibial loosening were seen at midterm follow-up 5 to 7 years. So when they investigated what they concluded was because the PCL was sacrificed and there was no provision made for replicating the function of PCL, which is a component of rollback. These knees, the total condylar knees, lacked the rollback. Rollback meaning the femur rolls forward on the tibia as we go into knee flexion. And just to illustrate what rollback is, this is a natural knee. What happens in a natural knee? On picture A, you can see the medial femoral condyle. This is an MRI of a live patient doing knee flexion. The posterior rollback is seen on the medial side. You can see that the femoral condyle is almost resting on the medial meniscus. Or if you see the lateral side, which is figure B, it almost subluxes off the tibia in a natural knee. And that's how we are able to achieve extremely high degrees of flexion in the knee joint. However, when the PCL is gone, we are not able to see this. So here I have shown what happens with no posterior rollback. The femur goes and hits against the back of the poly or the posterior part of the poly because the contact point is kind of anterior when there is no rollback in the absence of a PCL. So this is what happened with the total condylar knees. And when rollback happens, as is happening with the PS knee or with the CR knee, the femur rolls backward and it does not impinge or hit against the polyethylene here on the back. So just to give you a historical perspective, this is how PS knees came in. And this is why, just to show you a video of knee. So this is a knee that has been done, and when we flex it intraoperatively, you can see that femur nicely rolls back as we go to about 135, 140 degrees of flexion. This is intraoperative. Whether the patient gains this much range of movement is difficult to predict. So this is how actually the PS knees, this is exactly the purpose for which Dr. Insal brought in the PS knee. Insal and Dr. Ranawat, they brought in the PS knee exactly to replicate the rollback. So, however, over the last 10, 15 years or so, the ultra congruent designs have emerged as an alternative to PS and CR TKR. I think most surgeons use an ultra congruent design when they sacrifice a PCL and use an ultra congruent instead of a PS knee. That's how most of the use has come. So all knees have some mechanism to achieve rollback. PS knees use a cam and post mechanism. CR knees depend on a balanced posterior cruciate ligament to achieve posterior femoral rollback. The role of the rollback with UC inserts is not well established in current literature. There are a couple of studies. I will show them to you. So our objectives or hypothesis was PS insert will achieve a better rollback and better flexion than UC inserts due to the presence of a cam and post mechanism. This was the initial hypothesis that we had. So the objective was to compare UC and PS knees in terms of rollback in deep flexion, pattern of rollback from 0 to 120 degrees of flexion, and to see what the maximal intraoperative knee flexion achieved was. In terms of methodology, it was a prospective study, consecutive cohort of 20 patients, mean age of 66 years. This is the general varus knee kind of population. All patients were of primary osteoarthritis. All went robotic assisted posterior stabilized cemented TKR with a single radius femoral component design, which is triathlon, and a fixed bearing insert that we regularly use. PCL was sacrificed in all our patients, this cohort. The preoperative pre-resection qualitative balancing was done to obtain equal rectangular extension and flexion gaps using the Mako robotic system. So, I mean, quantitatively, these knees were balanced. So PS femur and tibia components were cemented. So in all these patients, PS femur and tibia components were cemented. And then for the study itself, first we put in the ultra congruent insert from Stryker, and then the PS trial components were placed, and then images were captured at 0, 45, 90, and 120 degrees of flexion. So this is with trial inserts. The components have been cemented. A PS femur and a standard tibia have been cemented. And then we changed only the poly. First, we put the UC insert, put the knee through range of movement 0, 45, 90, and 120, and captured the how images were captured. And then we put the PS inserts into the same thing, and then we captured these same images. So how to measure rollback? We use this kind of methodology. So we mark the contact point between the femur and tibia, the lowest point where it contacted where the femur contacted the tibia, and then rollback was expressed as a percentage of the sagittal dimension, meaning if it is 70 from the anterior edge of the insert to the contact point and 30 from the contact point to the posterior edge, then the rollback would be considered to be about 70%. Here in this example, I've shown you how we estimated the rollback. So it is expressed as a percentage so that we can kind of uniformly compute it across many knees. And then maximum flexion with each insert was also recorded. And then the statistical analysis was done using the paired t-test. So this was what we found at deep flexion of 120 degrees. At 120 degrees flexion, there was no difference between the rollback of the PS inserts and the ultra congruent or the CS inserts, as it is called in Stryker. So there was no difference in rollback at deep flexion of 120 degrees. I've shown the p-values here. It was not significant. And the graph itself shows it was very close to each other. The blue is the CS and CS or ultra congruent insert, and the orange is the PS. However, if you look at between 0 and 45 degrees, this is what we found. So the orange is the ultra congruent inserts. They tended to have a slightly posterior starting point, and then as they go from 0 to 45, there was some paradoxical anterior movement, and this was noted in about 13 out of 20 cases with the ultra congruent insert. None of the cases in the PS showed this kind of paradoxical anterior rollback or anterior sliding in the initial 0 to 45 degrees of flexion. Between 45 and 90 degrees of flexion, both inserts show consistent posterior rollback. They've rolled back from what they were at 45 to 90 degrees. So here the pattern was consistent across both inserts. The maximum intraoperative flexion was 130 degrees with the ultra congruent insert, 130 degrees with the PS inserts. This is what this was with the flexion, intraoperative flexion. So for comparison, we had one another study done with a similar design using navigation in 2016. This was done with a different knee system, the Columbus knee from Esculap. In their study, less femoral rollback with the ultra congruent inserts as compared to the PS inserts. This is what they had observed. Their sample size was about 30 knees. So we were thinking of why this difference could have happened. And one possible reason is the design of the implants itself. In our study, we used a anterior lipped insert. It doesn't have an elevated posterior lip. However, the Columbus knee had an elevated anterior lip and an elevated posterior lip, meaning it's a truly conforming insert. The insert that we used is called a cruciate stabilizing insert. It has only an elevated anterior lip, no elevated posterior lip. So this probably allows a little bit better rollback. And secondly, the femoral component we used was a single radius. In their study, it was a multi-radius femoral component. And ours, it is a quantitatively balanced extension and flexion gap using a robotic system. In their design, it does not quantitatively balanced flexion and extension gap. These are things that could contribute to differences in their outcome. So this pattern of rollback, mid-flexion 0 to 45 degrees, paradoxical rollback was seen with the UC insert. And this has also been recorded in previous studies by Kim et al. And the Fritsch et al. Study that I initially showed. Whether this has any consequence in terms of where mid-flexion instability is not known well. Deep flexion, mean degree of difference was only 3 degrees. I think it was probably not significant. Only 3 degrees difference in intraoperative flexion between ultra-congruent inserts and PS inserts. There were some limitations of study based on intraoperative findings alone and doesn't account for the dynamic changes that happen with in vivo activities. And based on one specific design of UC insert used with a single radius femoral component and quantitatively balanced knee with the robotic system, may not be applied to every kind of ultra-congruent insert, may not be applicable to other femoral components, and may not apply to knees that are not very well balanced. So the strengths were both inserts were compared with the same patient with no other variables. Because it is an intraoperative comparison, we are only changing the insert. All other variables are remaining the same. I think that's what we got from our study. Yeah. In conclusion, our study shows that anterior lip ultra-congruent inserts achieve good posterior femoral rollback comparable to PS inserts in deep flexion in a qualitatively balanced knee with a single radius femoral component. This is what we concluded from our study. Yeah, I think that's what we got.
Yeah, that was a good paper, Arun. I have a few questions. The insert, where the original insert, you just locked it in and then you unlocked and you did the PS insert, or was it the trial?
Yes,
It
sir.
was a
We can lock in that insert into the component. First trial it with the ultra congruent insert, record everything. But we have to use a femur that can take both. So we have to first fix a PS femur. The
Okay.
femur was PS, the tibia
And
was
then you
selected so that
and then you did a trial
then
liner
trial insert alone was changed
for both. And you did okay. Since it was a PS, everything was sacrificed, and then you checked with both.
Yes, sir.
Okay. So we did it in around 2005 in KMC. We did the same study, and we found in an X-ray at that time, and every time it was a paradoxical anterior rollback, which is very well established. But what causes the posterior rollback?
I think one is this is anterior stabilized, meaning it is the trough point is about 2/3 if you look at the insert design itself, sir.
Okay. So
the
anterior
deepest point is at about 2/3 of the anteroposterior diameter or the anteroposterior length. The deepest point is at 2/3 of the distance. That is how this insert is made. So if it is reasonably snug fit in flexion, then it tends to roll back to at least that point, and that's what we saw, about 70% rollback in deep flexion. If it is not balanced in flexion, then it may move everywhere. I think it may not be exactly rolling back.
Okay.
The original Ranawat design had the the center point at exactly the midpoint. And that's why it had a very limited flexion. And now all designs of the UC poly, they moved the center point back roughly 2/3, 1/3. And that's why that problem was solved and we were able to get flexion.
So even in the PS, it goes only up to the 2/3, 1/3. It doesn't go further beyond. Is it right?
No. The 2/3 is the rollback. So you'll get, instead
Yeah.
of being in the center, if you say 50%, now we are at 70, now we are 66%. So that's
Yeah.
the rollback. So
Yeah,
the
I
tumor rolls
understand.
back on the TV.
Yeah, I understand that. But in the PS also, it rolls back only 2/3, 1/3. 2/3 only it rolls back. Or does it go beyond that?
It depends where the box is, I mean, where the the post is situated, sir. I think it might vary depending on little bit on the where the post
Design.
is situated. Generally,
Okay.
I mean, in this design, I think it rolled back about 70%. That is what we are.
Okay.
So the first problem to solve is actually the paradoxical anterior translation. So I think the purpose of locating the contact point posteriorly is really to deal with the question of paradoxical anterior translation, not so much the fact that the engagement of the post and the cam happens. The engagement will happen a little late anyway. But what it will try and eliminate is the paradoxical anterior translation, because your contact point is a little posterior.
Mithun,
Yes, sir.
can I make this presentation of mine so that we can have a common discussion?
Yeah. I was thinking the same, sir. Sir, we can have Suri sir's presentation, sir, and then we'll have the discussions for the both presentations at the same time. Thank you, sir.
Yeah. Now, before Dr. Suri's, Arun, a fantastic study. This is how studies must be done. Very useful data and very nicely done, Arun. Congrats.
Thank you, sir. Thank you.
Nice, sir. Nice, sir. Yes, sir.
Arun, nice paper, Arun.
Thank you,
Good
sir.
publications, all right.
Sir, you can start sharing, sir.
Yeah, just a minute. It wants me to do something.
Arun, excellent paper. Before Suri sir starts off, when is your maximum rollback happening? Between what degrees?
The maximum rollback is seen in deep flexion, sir. I mean, deep flexion 120, 130. As it flexes, I mean, unless it rolls back more, it won't flex more, sir.
Yeah. But the initial rollback starts anywhere between 15 to 60 degrees. That's when it actually starts rolling back, right?
Sir, in a natural knee as well as in a PS knee, it starts from 0. It consistently rolls back, sir. It does slowly and progressively rolls back. PS is not as consistent as a normal knee, but almost, I mean, that is the closest that we got to a normal knee in terms of rollback, PS knee. So in this, in UC, there is a little bit the initial anterior translation, then after 45 degrees, it rolls back nicely. And probable reason is at 45 degrees, knee is a little bit laxer than at 0 and 90, kind of mid-flexion, a little bit laxity, despite, that's the natural knee. Natural knee is lax in about 20, 30 degrees. So it becomes a little bit lax and then it slides anteriorly with the cruciates not being there.
Arun, congrats, fantastic paper. Do you think probably the particular insert in the striker is, a very flat insert? There is very poor conformity between the femur and the plastic, and that could contribute to the, the paradoxical anterior translation. Do you think that could be one reason?
No, sir. This paradoxical anterior translation in mid-flexion has been shown in with other designs also. I think I showed you 2 other papers where they have done the study. They have also noted same kind of paradoxical rollback with 2 other insert designs, completely different.
Now, having now used quite a few medial pivot knees, it occurs consistently whenever there's a medial pivot occurring. There will be an anterior. You can actually see it moving anterior, and then as it flex, it moves posterior. So I'm not sure it is paradoxical, actually. It is. That's just how the biomechanics are.
Arun, what is the problem with having that initial anterior translation for just the post 45 degrees? Does it cause any clinical issues or?
We are not sure, sir. Nobody knows. But I mean, there is too much sliding. First, it slides anteriorly and then it slides posteriorly. It can increase wear. It's like I think what Ajit Yadav sir was coming to. But it is not well established what that paradoxical anterior rollback in initial midflexion is going to do.
The normally doesn't have. I mean, there are three.
Normally doesn't
yeah,
have. Normally
yeah.
doesn't have.
So there are three things: a slide, glide, and a rollback. So initially you have a slide, which is a pure translatory movement. Then you have a glide, which is a combination of some degree of rollback and a slide happening, which is over a shorter period. And then the terminal part is a pure rollback. And the rollback function is directly related to the presence of the posterior cruciate. So if the implant is going to substitute for the posterior cruciate, I mean, that is the whether it does so by adjusting the slope or by or it's an implant, it's a sort of a function of the implant. So the terminal rollback has to happen in order to get an increased range of flexion.
Arun, do
If
you
sir
think
is
the-
ready, then I think we'll have the discussion.
Arun, do you think the anterior paradoxical shift can actually be due to the absence of the ACL?
Yeah, I mean, ACL is not there, PCL is also not there, sir. So both are not there. Both are not there. It is, I think, more to do with PCL not being there.
So
No,
is
I'm-
there any difference between, using a UC insert with the PCL still intact or without the PCL?
Yeah, I mean, that is, when they, sir, can we have the discussion after Suri sir's thing? I think.
No, I think he was
Trying
working
to
on
present,
something,
sir.
so that's why.
Suri, can start sharing, Suri.
Sir, doesn't seem to be online.
1 second, sir. I'll talk to him.
Yeah, okay. So with the, I mean, whether to use it with PCL or without PCL being there is again, that is also debated. So if you have a PCL that is intact and we use a fully congruent, like the Aesculap poly or the Smith and Nephew poly that has an elevated anterior lip, it could cause what they call a kinematic conflict, because as it rolls back, it kind of an elevated lip with the PCL being there, it could prevent flexion and rollback in that last degrees. So if you have a posteriorly elevated lip, I think there are concerns.
Arun, can I answer on this?
But if you don't have an elevated posterior lip, you can use it with or without PCL being there.
So to answer this, we tried intact PCL also using UC insert. But if it is a female patient, if the PCL is a little bit more lax than the male patients, that patient doesn't have any issues in the post-operative, sir. If you're going to use a tight PCL, then you're going to use a UC insert, then the flexion has got restricted and the patient complains of some issues, sir. So it's better if it is a tight PCL, you have to erase it and put the UC insert, sir. If the lax PCL, you can try with the UC insert, nothing will happen, sir.
So lax PCL means basically not working.
Yeah, that is not working. That is the concept, sir.
Yeah.
So-
Now that we are doing more of these alternative alignments, so we tend to not to accelerate the femur. So the posterior space, even when you do a UC insert, we find the posterior space is slightly more lax laterally. And these are the patients who have the medial pivot. You can actually see it in even the UC insert. Some cases, not all cases, will have that paradoxical. And I'm not sure it's a bad thing at all, because that's exactly what we see in the middle pivot. So these UC inserts act like a MP insert. So in fact, I'd be very happy when I see that in the UC insert. I'm very happy that I'm seeing that.
You're happy about the paradoxical translation?
Yes, so in the middle pivot, every knee does that. Every knee does it. I can see it as you come to extension, it'll really come anterior, and then as you flex, it'll really the lateral curve will
But
go
is
posterior.
that happening only on the lateral, on the medial condyle?
Only on lateral, only on the lateral side. Only on the lateral side.
Only on the lateral. Well, that's not a true translation then.
Well, that's what Arun is documenting is also the same thing actually.
Yeah, both the
Actually, I
condyles-
thought both the condyles were translating anteriorly, not the lateral alone.